And now I am very pleased to welcome Dr. Kristine Kuhn, our medical grand rounds speaker. Dr. Kuhn is an associate professor of immunology and microbiology in the Division of Rheumatology here at the University of Colorado. She's also program faculty within the Department of Immunology and Microbiology. She holds the Scoville Endowed Chair and as of this summer is the division head of rheumatology. Dr. Kuhn is also the director of the Notobiotic Mouse Core Facility at the University of Colorado School of Medicine. She did her undergrad training at the University of Kansas. She was a medical student here at the University of Colorado in the MSTP program, so she concurrently earned her PhD at that time in immunology. She did her residency training at Barnes-Jewish Hospital at WashU in St. Louis, her fellowship also at Washington University, and her advanced training as we described above. She is a recognized expert nationally and internationally, and has a remarkable ability as a physician scientist, which was recognized early on in her training. Most recently, she was named a 2017 Rising Star here at the University of Colorado. She was also named the 2017 Web Wearing Early Career Investigator from the Boettcher Foundation. In 2018, the Spondyloarthritis Association of America awarded her the Bruckle Early Investigator Award. And then also in 2018, she was one of the Department of Medicine's outstanding early career scholars. She holds a number of local, regional, as well as national leadership positions, including being the current chair of the American College of Rheumatology Committee on Research. She has been continuously funded and supported in her work since completing her fellowship. She is currently supported by an NIH U01, where she's the associate director of the Center for Mucosal Immunology here at Colorado. She's also an investigator on an R21. She is a co-investigator on a single RO1 and then is the PI on her own RO1, looking at the role of bacteria produced indoles in the development of autoimmune arthritis. She has several other awards from foundations and divisional access. Her work has led to 30 original publications, as well as 100 abstracts, talks, chapters, and other manuscripts, truly recognizing the expert that she is. She's also a tireless teacher. She teaches our residents, our fellows, our medical students, and she's been a mentor to many of those folks. So it really is a pleasure to welcome our new division head of rheumatology to Medical Grounds.
Thanks, Jeff. Let's see. Okay. I'm really excited to be here. I hope you enjoy this talk. I try to make it mostly medicine and applicable to the broad audience that does attend. And so I want to start out by talking about the barriers to understanding axial spondyloarthritis. And so we're going to talk about a lot of the barriers that have hindered this field. And then I'm going to end with talking about my favorite barrier, the mucosal barrier, a little bit different kind of barrier, and how we've been working at that barrier to understand the pathophysiology of the disease. And so just real quick, I've had some disclosures with some consulting, and I do have a investigator-initiated grant, but I'm not going to be talking about specific therapeutics. These are my learning objectives. I really want everybody to be able to walk out of here and say, I kind of know what axial spondyloarthritis is. I think I can recognize it when it's in front of me, and I at least know what I need to do to start working up for this diagnosis and getting them into a rheumatologist. And then I also want you to understand what diseases connect, because axial spondyloarthritis really belongs into a family of diseases. And so I want you to start associating how these things go together. And that really comes down to the pathophysiology. So I'm going to first start out with an audience question. What is axial spondyloarthritis? Does anyone know? And the rheumatologists in here can't, or my lab can't volunteer. Just shout it out. It's a spinal arthritis. Axial, yes. Spinal arthritis. Are there any other features you know about axial spondyloarthritis? Sacroiliitis. Exactly. One more. Yeah. Seronegative. Great, great. These are all great answers. So there is an old concept. This is what I was taught in medical school. I think many of us have seen this photo of this progressive arthritis affecting the spine, causing limitations in range of motion and progressive limited range of mobility, and then essentially having this kind of hunched, stooped appearance. The old concept, we called this ankylosing spondylitis. We're moving away from that term. We used to think, and we still do, this affects primarily young people, but we're starting to recognize it because people ignore the symptoms for a long time and they don't present to us until they're older. We thought of this as being a white man's disease, and we're starting to learn it's not. And then finally, the fusion of the spine. Now, what we're starting to see clinically, we know from some epidemiologic data that's emerging that men and women have equal prevalence. This is not a white man's disease. It's a global disease. And so these are some estimates. About 1% of individuals worldwide will have axial spondyloarthritis, and the prevalence based off of this color coding. And I could contend that maybe some of these places where we have lower prevalence might be just because we don't have rheumatologists or epidemiologists really looking at this problem. And so that leads me to my first barrier of this disease is we have a limited knowledge of the epidemiology and outcomes in diverse populations. For a very long time, it's been studied in white men. But what we've learned is that there's no longer a sex difference in the prevalence of this disease. And so when you see a woman in front of you who's having back pain, you should be thinking axial spondyloarthritis, not only in men. Women experience a greater diagnostic delay, and I'm going to show you this graph here. And so what you can see on the lines here, these triangles on the left, blue are men, red are women. This is the age in years on the y-axis, and this is basically our prevalence data. And this is showing us when symptoms begin, and in the circles, when people are ultimately diagnosed. And there's a delay in diagnosis. We've known this for a long time, an average of 10 years delay in diagnosis from the onset of symptoms. But what you can appreciate here, I kind of drew it out with arrows to show it a little bit more easier to visualize, that delay in diagnosis is greater for women. And we are starting to learn that women are less likely to respond to treatments and stay within a treatment. Once they start on a therapy, they're more likely to have to switch. And despite maybe some subtle differences in the clinical manifestations of the disease, we know that the disease burden is very similar in men and in women. Now, how does this translate to different racial and ethnic groups? I think we're still lagging as a field in that regard. And so hopefully someday when I give this lecture in a couple of years, I will be able to inform more on that. And so as I noted, we're starting to move that classification or that diagnosis and nomenclature of ankylosing spondylitis towards something called spondyloarthritis. And classifying it based on the features, the clinical features. And so is this axial spondyloarthritis? And based on the features here, do you have spine involvement? That means you're going to have axial. You may have peripheral symptoms, but if you have any spine involvement, you're going to be classified as axial spondyloarthritis. If you have no spine involvement, it's going to be peripheral. And within axial and peripheral, we can have things like psoriasis and IBD in combination. And so, my animation, okay, it flashed, but this is another audience response. What is inflammatory back pain? Who knows the definition of inflammatory back pain? Go ahead, shout it out. I'm getting blank stares, okay. So age of onset, less than the age of 40. Duration, usually greater than 3 months. Insidious onset. Morning stiffness, greater than an hour. Improves with activity, worsens with rest. Pain can wake the patient early in the morning. I can get patients coming into the office saying, you know what? I fall asleep, no problem. But about 3, 4, 5 a.m., I'm waking up and I cannot get back to sleep because I am so stiff. They can have alternating buttock pain as opposed to sciatica, where you get that buttock pain or it just kind of goes all the way down the back of the leg. This can kind of affect both sides and generally responds to NSAIDs. Now, on this side here, just kind of shows you these different features and the odds ratios of them correlating with actually having axial spondyloarthritis. And so you can see some things, back pain improves with movement, has a greater odds ratio than say things like age of onset less than 40 years. And if we look, if you have 3 of 5 inflammatory back pain features present, the sensitivity and specificity, the sensitivity is great, 95%, but the specificity is absolutely horrible at 50-50. flip a coin to know whether or not the patient has axial spondyloarthritis. So this is barrier number 2. Really, we have limited knowledge amongst particularly non-rheumatologists of this disease. And that's kind of replicated here with, trying to, what's that definition of inflammatory back pain? And I think that's the basis. This was a study done among GPs and non-rheumatology specialists in B here, looking at whether or not GPs in the UK or non-rheum specialists in the UK could identify features of inflammatory back pain. And very few people could identify all 8 features, 5% or 28%. Most people could identify 4 to 7 features, but you still had a sliver here of people that weren't even able to identify any features of inflammatory back pain. So we need to do better. And I can tell you I'm part of the Spondyloarthritis Research and Treatment Network, and one of our big missions as an organization has been doing a lot of education amongst, we'll admit it, we're trying to educate the chiropractors, and we're trying to educate the orthopedists, general practitioners, whether they be internists, family docs, things like that. We're trying to really get out there, and not in front of just MD groups, but also our advanced care providers groups to broaden the knowledge about this disease. So exam findings. So we're utilizing history. We're going to utilize exam findings to help make a diagnosis of axial spondyloarthritis. And so the key here is that the pathogenic site is the enthesis. And so that's where your tendons or your ligaments are inserting into the bone. And recognize that's anatomically different than, say, the synovium, which attaches at that cartilage bone junction. And so it's a little bit different of an anatomic site. And so you're going to see, instead of synovitis, you're going to see more tendonitis and tenosynovitis occurring. And these are the spots where generally we are going to evaluate for the enthesitis. So I know what you're all thinking right now. Is this enthesitis or is this fibromyalgia when you look at all those points? It's a really good question. We struggle with this as rheumatologists too, trying to identify what's inflammatory, what's not. And so a lot of studies have focused on trying to sort out tenderness from fibromyalgia versus enthesitis from true inflammation. And so they're not mutually exclusive either. And so we're frequently reassessing and trying to sort that out clinically. So with enthesitis, we're looking for more objective findings. So we're looking for other features of spondyloarthritis, some of the extra articular manifestations like psoriasis, swelling, warmth, erythema, so objective inflammatory findings. We want these qualitative features, improvement with mobility or worsening with immobility. And then sometimes therapeutic trial. Let's just try some NSAIDs and see if you feel better. They may not 100% resolve with NSAIDs, but you should see some subjective improvement with some scheduled NSAIDs. Fibromyalgia. Of course, you're looking for other kinds of symptoms, mood disturbances, sleep disturbances, mood symptoms and associations, worsening with mobility. Stress is a huge trigger for worsening of fibro, and they're going to usually fail any kind of therapeutic intervention. Other exam maneuvers, I think we've probably learned these in medical school. So I feel like when I ask the residents if they've ever done a Shover's, most haven't. I don't often do a Shover's because that's going to be more advanced disease. But I'm really looking for a patient to be able to, what's their spinal mobility? Can they forward flex? Can they extend? Can they rotate? I'm looking for things like dactylitis. I was told these look like little jimmies, or no, little smokies. It's my favorite description of dactylitis. Some arthritis, you can appreciate kind of the swelling. And again, it's not just limited to the wrist. You can see it's kind of diffuse. You lose kind of like the veins and the ligaments of the hand and it just looks kind of swollen. And that's really characteristic more of that tenosynovitis instead of just synovitis. You could try doing Fabers and Gainslands, and rheumatologists, especially spondy experts, are going to look at you and say, these are completely not sensitive or specific. But these maneuvers do stress the SI joints. And so you're trying to see if you can kind of recreate some of that pain within the SI joint with these different maneuvers. So what are some other features I'm looking for on exam or by history? And so, of course, psoriasis. Remember psoriasis, sometimes it's along the hairline. It likes to hide behind the ears, in the umbilicus, in the crease of the bottom. But also look at the nails. Pitting of the nails can be suggestive of psoriasis, and particularly arthritis, peripheral arthritis associated with the psoriasis. We're looking for uveitis. Now, of course, this is advanced disease when you're starting to see that pus layer. But the symptoms is really incredible sensitivity to light. And so when the patient flips the lights on in the morning or goes outside, they have intense pain. GI or GU infection. And so does anybody know what these are? This is like one of my most favorite medical words. This is gonococcus. That's right. That's gonococcus. This is keratoderma balanoragicum. And so usually like chlamydia. But we also think of IBD. And so these are some of the skin manifestations of IBD. So pyoderma gangrenosum and erythema nodosum. So looking for those kinds of things on exam. So, you know, we're basing this off of a history and exam, but what about biomarkers? And that's barrier number 3. We have none. As someone said, it's seronegative. And that makes this diagnosis even more difficult. So what about inflammatory markers? I often joke when residents come to clinic with me. I was told by Vicki Frazier at WashU when she became the chair of medicine there, and she was working with us as chief residents, and she told us one day, you either get an ESR or an MD, but you don't get both. And I always thought that was really funny because in rheumatology, we're looking for the signs of inflammation. And so we don't really need that blood work to tell us if there's inflammation there or not, because we're probably not going to do anything with it. And so when we look at patients with axial spondyloarthritis, particularly this is data off of early in disease, within the first couple of years of disease onset, you can see compared to people with chronic back pain, there is no difference in CRP or ESR. So inflammatory markers don't make or break a diagnosis here. And so I think sometimes that skews people, providers from saying, oh, well, your inflammation markers aren't up. It can't be a rheumatologic condition. And that's not true for axial spondyloarthritis. And so if the CRP, if anything's going to be elevated, it could be a CRP. If it's elevated, it's helpful. If it's not elevated, just move on. So HLA-B27, this is another one of my jokes with the residents. When you're in clinic, B27 is never the right answer. When you're taking boards, B27 is always the right answer. So as you can see, this is one of my soapboxes about axial spondyloarthritis, but as you can see here, HLA-B27 has a natural prevalence in populations. It's enriched in people of Northern European ancestry. And if we look at people with axial spondyloarthritis, you will see a prevalence from anywhere from 50% to 95%. It really depends on the demographics of that cohort. And you can see here, spondyloarthropathies, I mean, all of them combined, not just axial, will occur in about 2% of the population, and occurs in about 10% of people with HLA-B27. So after a lot of math, what you can walk away with, 80% of people with the gene don't get AS, 20% of people with AS don't have the gene. So where I find this HLA-B27 gene to be useful in some cases is prognostically. We know that people who have an HLA-B27 positivity are more likely to radiographically progress and start to look like that first picture that I showed in this presentation. So again, remember barrier number 1? Yeah, that's the problem with B27s. So imaging is really what it comes down to for us, and it greatly aids in the diagnosis. I think, you know, the one thing that if I can stress and have you walk away out of here with is image the pelvis. If you're looking at the L spine, you're going to miss it. You need to look at the sacroiliac joints. And so sacroiliac joints, though, are hard, really, really hard. And so what I'm looking for is I'm going to follow this SI joint on the iliac side all the way down. And I can see a margin here, but I start to lose it right around here. I'll do it on the iliac side. I got it, and then I lose it. And that tells me that there's some blurring of those joint margins. There's probably some sacroiliitis there. If I'm ever in doubt or I'm not sure, oh, sorry, I want to just say, If you're going after the lumbar spine and you're looking for the vertebral squaring on the left or the bamboo spine on the right, that's late stage disease. These are going to be slam dunk diagnoses, but we want to avoid this. We want to get them earlier than what's going on in the SI joints. So, but if you're ever concerned and you're not quite sure, get an MRI. Again, the key here is to get the pelvis. Even if the patient says, I'm having neck pain, get the pelvis. It starts in the SI joints and moves from caudal to cranial. So what we're looking for here, this can be a non-con. You do not need contrast for this. It can be a non-con study. We love to get stir sequences, but a T2 fat suppressed will do the job just fine. And so what we're looking for here is as shown really in this circle here, is we're looking for bone marrow edema. So this is a semi-coronal cut, and you can see the iliac here, the sacrum here, and this is the other iliac. And you can see kind of this bone marrow edema or this enhancement right around that joint there. And that's really what we're looking for to call sacroiliitis on the imaging. You can see some similar features in the L spine. Again, this is going to be more advanced disease, and you're more likely to miss an initial diagnosis if you're going after the L spine. But you can see here, as shown by circles, these so-called shiny corners because you've got increased enhancement there. But MRI is very sensitive. And so we can see a lot of sacroiliitis, but the history is critically important in getting that symptoms of inflammatory back pain, because a lot of people can get sacroiliitis. They can get it because, and this is basically people who have sacroiliitis, the incidence of sacroiliitis in different conditions. And you can see even runners, postpartum women, sometimes just because of the stress on the SI joints, you can get some sacroiliitis that's transient. So the history is critically important here. And so this is my treatment algorithm, and I'm happy to share this with anyone, but I really start out and start saying, okay, does the patient have a GI or GU infection? Because that makes my life easy. This is going to be a transient spondyloarthritis, reactive arthritis. It's going to be self-limited. It's going to go away after 6 weeks mostly. If not, if it's going on more than 6 months, I'm questioning my diagnosis. I'm going to treat it with NSAIDs, maybe some intra-articular steroids. Rarely are we going to go on to a DMARD or a biologic. So if that's absent, the next thing I need to figure out is if they have underlying IBD, because if they have IBD, that limits my choice of medications. And so yes, if they have it, I'm diagnosing IBD-associated SPA. It can be peripheral or axial, and that depends on the treatment. If it's peripheral, I can use oral DMARDs. But if it's axial, oral DMARDs don't work. We start with TNF inhibitors, JAK inhibitors. And I'm going to give a quick shout out here to Dr. Ahmed, who did some work prior to coming here and joining our gastro group that talks about use of dual biologics for refractory Crohn's disease. And we've been adopting that to our use of dual biologics to treat both axial spondyloarthritis and active Crohn's disease when both diseases are active despite a monotherapy. So if not, we start thinking about psoriasis. And at the end of the day, if we don't have any of those extra-articular diseases, we're going to be diagnosing this axial spondyloarthritis or an undifferentiated peripheral spondyloarthritis. All of these things start out with NSAIDs as first-line therapy, but I will tell you as a community, we are revising the guidelines. I think that's going to get removed, and we're going to go straight to TNF inhibitors as probably first-line therapy. Most patients come having already tried NSAIDs, and they're failing them because they're there in your office. So, so there's that. So I'm going to go now into really, this is where I spend most of my time thinking, which is my barrier number 4, the intestinal mucosa. And so why would a rheumatologist spend her time thinking about the intestine? Well, it's because if we look at the different types of spondyloarthritis, whether it be peripheral, this non-radiographic, which is a terrible, terrible name, it basically means that you have axial spondyloarthritis, your x-rays are negative, your MRI is positive. So think of the true word, what radiographic means, meaning radiographs, x-rays. And in ankylosing spondylitis, which means you do have X-ray evidence of disease. And in that, black is normal, but if you add up the acute and chronic inflammation as assessed in individuals, you get to about 50% of individuals across the board having some kind of gut inflammation when endoscopy is done. It may not be overt, it might be subclinical in that these patients are not having any gastrointestinal symptoms, and it might only not be macroscopic, it might be microscopic when they do biopsies and look at it pathologically. However, 50% will have disease, only 10% will end up having overt IBD in association with this. On the converse side, in individuals with inflammatory bowel diseases, whether it be Crohn's disease or ulcerative colitis, about half of those individuals will have joint pain. About a quarter of them have an inflammatory arthritis. And so the other thing that we've learned is that the correlation between radiographic severity, as shown on the y-axis here, and gut inflammation, histology shown on the x-axis, is you can see that there's a correlation with more gut inflammation, more radiographic progression. So this has really propelled a hypothesis of the gut-joint axis, that something in the gut could be going on to stimulate and trigger joint disease. Furthermore, if you look at the spectrum, as I said, spondyloarthritis belongs in this family not just being axial and peripheral arthritis, but inflammation in the eye, the uveitis we talked about, inflammation of the skin, the psoriasis, the gut, IBD, some more peripheral disease. But if you look across these diseases and start to say what is common amongst these, you can see that there's some shared genetic risks, particularly of the IL-23 receptor, STAT3, which is downstream signaling of IL-6 and other what we call Th17 pathway cytokines. And you're going to see elevations of that same family of cytokines, TNF, IL-12, 17, 23. So this starts to get into the immunology alphabet soup that I hope I can condense down into a simple slide here. This is a thing called Th17 immunity. Those that live in rheumatology, live in the IBD world are familiar with this Th17 immunity. It's really important for fighting off extracellular bacterial pathogens. It's important for fighting off fungal infections. We find that if we block IL-17 in particular, you have increased risk of oral thrush and other mild fungal infections. But it's also important and increasingly recognized in autoimmunity and chronic inflammatory or sterile inflammatory diseases like IBD. And so how does Th17 immunity occur? Well, think about your antigen presenting cell. It's going to present an antigen to a naive T cell. And if these cytokines are in that milieu, that naive T cell is going to become a Th17 cytokine. And you'll notice a lot of times we treat our rheumatologic diseases by blocking IL-6, blocking IL-1 beta. And so it really lends credence to this pathway being important to the pathophysiology of disease. Now, not only do these T cells produce or Th17 cells, they're usually triggered by IL-23 to then make things like IL-17. I'm mentioning these things because they are therapeutic targets for a lot of our diseases. We're blocking IL-23 to treat psoriasis and psoriatic arthritis. We're blocking IL-17 to treat psoriasis, psoriatic arthritis, axial spondyloarthritis. But other cell types have emerged. What happened is that there were clinical trials utilizing the IL-23 blocker for axial spondyloarthritis. Works in psoriatic arthritis. Why wouldn't it work in axial spondyloarthritis? Guess what? It failed. And that's when we started to learn that there are probably other ways here to make IL-17 without IL-23 being upstream, and that might be more relevant. And so we're starting to look at these innate-like cells, ILCs. These are innate lymphocytes. Basically, they're T cells without T cell markers, gamma delta T cells, and mate cells. Mates are mucosal associated invariant T cells. They really react to microbial metabolites in the environment. These all can produce IL-17. And so How do these cells get generated? Well, these cells are generated in the intestinal mucosa. And so again, linking back this gut joint axis, these cells that seem to be really relevant to the pathophysiology of arthritis seem to be getting generated within the intestines. And so we know that intestinal dysbiosis, or changes in that microbial community that live in your gut, we know that those change in people with spondyloarthritis compared to people who are controls. We know that those change in people with IBD compared to controls. We know that the patterns from one study to the next are not the same, so it's probably not one individual bacterium that's important here, but probably a community effect. And how those communities can affect the host, whether it be the epithelial barrier itself, how tight is that barrier, or could it affect these cells that hang out right under the barrier? Could be through either bacterial products such as antigens, but also metabolites. We know things like Sean, I'm seeing in the audience, looks at how butyrate, a short chain fatty acid, can be tolerogenic and help immune tolerance get established. But there's other metabolites that we've been looking at. I'll show you a little data. Indoles. Indoles, does anybody remember from microbiology and doing like the COVAX reagent to test for indole producing bacteria? Well, not only is that used for quorum sensing for those indole producing bacteria, but it turns out that they can penetrate the barrier and modulate our T cell responses. And I'll talk a little bit about that. And so all of these things can modify barrier permeability, innate immune cell activation, adaptive immune cell activation. And so it really is kind of a little microsystem that we are living in symbiosis and reacting to the microbiota. And so these Th17 pathway cells, like I said, they develop there in the gut in response to microbiota and microbial products. And we find them expanded in individuals with axial spondyloarthritis. So if we look at their blood, we can look at these MATE cells, gamma delta cells, these ILC3s, and we say, okay, how many IL-17 producing cells are in the blood versus the synovial fluid here? And we can see in axial spondyloarthritis, but not RA, these seem to be expanded. Similarly over here, maybe some expansion in the blood, and here as well. Okay, very interesting. So they're getting developed in the gut. We see them expanded in the blood. We're seeing increases in IL-17. So how does that relate to the development of pathogenic bone formation and the fusion of spine? And so a lot of basic science has gone into showing that, you know, whether IL-23 is relevant or not, these different cell types end up making this IL-17 molecule that acts on the local mesenchymal stem cell, the mesenchymal stem cells locally within the joint, whether it be a peripheral joint or the axial joint, and stimulates things like Wnt and BMPs that causes osteoblast differentiation, blast being build, class being chew. Yeah, so it's going to stimulate those osteoblasts to build up the bone and end up giving you that pathogenic bone formation that causes fusion in the spine. What's really interesting is that many of you probably know we use TNFs. Like, we love TNF inhibitors in rheumatology, don't we? And what happens, and so TNF, we use this a lot to treat axial spondyloarthritis. It turns out TNF can synergize with IL-17. So synergy being, it's not an additive effect, it's an amplification effect. And so TNF and IL-17 can synergize to really put pressure on this system that leads to pathogenic bone formation. So as I alluded to, human and animal studies demonstrate that there's correlations between the intestinal microbiome, whether it be like Prevotella copri or Akkermansia. These can lead to intermediates like short chain fatty acids, medium chain fatty acids, this expansion of Th17 cells, more IL-17. But what's this connection to the joint? How are we getting to that? And so we started looking at this a few years ago, collaborating with the IBD group here, because while I can do mouse colonoscopy, yes, I'm proud of that, I cannot do human colonoscopies. And so the GI, the IBD group have been fantastic collaborators for us in doing this. And what they did is they helped us obtain from individuals with axial spondyloarthritis versus controls, people who are just going in for their routine screening colonoscopy, and helping us get some swabs of the mucosa to be able to look at the microbiome, so the bacteria present there, but also to get little pinches of tissue so that we could look at the metabolites. What has the host absorbed from their microenvironment? And we sequenced that. So we took the microbiome, we sequenced, what could we find? What kinds of genes are there? And what Adam found is that there seemed to be enrichment in this tryptophan pathway. So we're talking turkey here. And so tryptophan is a dietary metabolite. It's an essential amino acid. We cannot make tryptophan, but our bacteria can. And what's shown here in black are the pathways to tryptophan synthesis, shown here, that can be done by by bacteria that were enriched in healthy controls. But the genes that were enriched in the individuals with axial spondyloarthritis are the ones in red. And you can see that they were moving away. So that microbiome is moving away from tryptophan synthesis into production of indoles. And so Adam verified this when he looked at the metabolites in the intestinal mucosa. He saw an enrichment for tryptophan catabolism in axial spondyloarthritis. So PCOA plot here. I am not a computational biologist, so my understanding of these plots is that the more things separate from each other, the more they're different. And as you can see here, so we actually had quite a few different individuals. We had people with Crohn's disease, Crohn's with axial spondyloarthritis. And let's just focus on the red versus the light blue. Axial spondyloarthritis versus our controls. Our axPA is here, our controls are here. So they've moved apart. Then we did this thing called a volcano plot that basically tells us what are those things that drive those clouds to separate from each other. And things going to the left are enriched in healthy controls. Omega-3 fatty acids, you know, those healthy things. Yeah, those are enriched in healthy controls down in axPA. Higher in axPA are these things within the tryptophan synthesis or tryptophan catabolism pathway. So tryptophan can go into indoles, it can go into serotonin, and we saw that happening in those individuals. So what does tryptophan metabolism have to do with arthritis or the development of spondyloarthritis? And so what we can do in the lab is we can model this in mice. I promise I'm keeping the mice to a minimum in this talk. So one model we use a lot is this collagen-induced arthritis. We basically inject mice with cartilage collagen with a strong adjuvant immune stimulant. And we give them a couple injections, and then they start to develop some swelling of the paws that can look like spondyloarthritis or rheumatoid arthritis. And so it's kind of a generic model we often use to understand cause and effect. And so what a former postdoc and now MD PhD student, Brenda, who's sitting here, has been doing has been modulating tryptophan in the diet. As I said, tryptophan is an essential amino acid, so you can't give the mice completely tryptophan deficient diets. So even though it says tryptophan deficient, we actually give them a little extra tryptophan diet on the weekends so that they don't like really tank. And then we give them that diet plus indoles. So we're adding back those indoles that we were seeing increased in the people with axial spondyloarthritis. And it turns out that if you remove or reduce the tryptophan in the diet, they are protected from arthritis. These are days on the x-axis, the severity of arthritis on the y-axis. When you start to add back that indole, as shown in red, you can see that arthritis comes back and looks like the mice on a normal chow. And when they looked at the T cells in these mice, getting back to that Th17 story, what we found shown here in the middle is in the red, those mice that got indole versus vehicle started to expand their Th17 cells, both in the spleen and in the colon tissue. So it seems like there's some connection here between, this microbiome that changes when you have disease. It's starting to break down that tryptophan into indoles that seems to promote Th17 immunity and arthritis. But how do you get to the joint? And so another graduate student in the lab who just graduated, Adam Lefferts, was doing this. So this is the mouse colonoscopy we do. We have this great model where the mice have a green fluorescent protein. And if we give them light at 405 nanometers, that green fluorescence switches to red. And so we use the colonoscopy to expose the distal colon to that wavelength so that we only label cells in the gut. And so you can see here, x-axis are those green cells, y-axis are the red cells. So those are the cells that have been converted to red emissions. And we then looked at the enthesis. At baseline, the time we convert them, green again on the X, red on the Y, we see no red cells in the enthesis right after we do this photoconversion. 72 hours later, we start to see those cells. So this is evidence that we have direct trafficking of T cells from the gut to the joint. Pretty cool. So we asked, what are those cells that have trafficked? And so when we look at those red cells, not a lot of them are making TNF. And these are T cells, mind you. So we think these are Th17 cells because we see that these cells are starting to make IL-17. And this almost tells us the fact that there's no IL-17 producing green cells and only in the red cells are producing IL-17, that all of those Th17 cells are really gut derived. We also see that we're recruiting in gut derived regulatory T cells. And so there's probably a balancing act that's going on here, is that you're recruiting in both regulatory and inflammatory T cells. And depending on maybe your genetic background or whatever triggered some inflammation in your joint, you're either going to resolve inflammation or you're going to end up getting that pathogenic bone formation. And that's kind of shown here. And so what we think is going on is you've got this microbiota producing some indoles affecting the development of Th17 cells and potentially other IL-17 producing cells that we can see trafficking to the joint. And it really comes down to this balance between regulation and inflammation as to whether or not you're going to end up with spondyloarthritis. So I'm going to conclude there so that we have plenty of time for some discussion. But despite many barriers to our knowledge of spondyloarthritis, I think we're making headway. We're starting to get a better appreciation for disease disparities that have plagued the field for a long time. We are starting to investigate potential biomarkers. I hope that, sometime in the next few years, I'm going to do a research and innovations conference and talk about the biomarker work we've done, because that's really cool. But I think we're pretty confident here to know that the critical barrier is a mucosal barrier. And that's key to the pathophysiology of this disease. It's giving us insights into not only what's triggering this disease, but also what are some novel targets for therapy. And so, of course, we're very interested in this trafficking of cells from the gut to the joint. And is that an opportunity for therapy? So I'm going to end. I have shouted out to a lot of people who have been incredibly productive in doing this research. My current lab, I love my lab. They're fantastic. They're amazing. They make me look good. I have a lot of collaborators, both within rheumatology, within gastro, across the campus. And of course, we have some external collaborators and funding sources. So happy to take questions.
All right, open this up for questions to our audience. Yep. Right.
Kristi, thanks very much. That was wonderful, and welcome to the department leadership. The question I had, and I think if I heard it right, is the SI joint is usually an early joint to be affected, and you showed the beautiful trafficking which goes through the bloodstream, I suspect. Why does it start in the SI joint and move up?
Great question. So one of our limitations in animal modeling in this disease is that they're quadrupeds and we're bipeds. And so some of it is probably mechanics. There is some really interesting literature that was done in Europe showing that there is mechanical loading and stress to the joints that primes them for the pathogenic inflammation that occurs. But why that? One other guess that I have, and I have no data on this, but is that the distal colon lymphatics drain to the inguinal lymph nodes. And I think if I'm right, the SI joints also drain to the inguinal lymph nodes. And so maybe there's some of that shared immune circuitry.
So that was kind of a related question. So it was a great talk, Kristine. So, with the innate T cells that you've been studying in these Tregs too, what's kind of driving that localization to the joints and that balance in terms of how they're localizing to these areas that are affected?
I want to know the answer to that question too. So we have started a collaboration with Fan Zheng who's a new faculty member in our division and a computational scientist. And she's going to help us using some single cell sequencing and our photo labeling experiments to hopefully get to that question. So stay tuned.
Christy, I'm wondering if you could comment on the prevalence, heritability of ankylosing spondylitis, whether through GWAS or family studies?
Yeah, so most of the genetic studies have been done out of the UK and are very much enriched for Northern European populations. And so in those populations on the GWAS, there's a huge HLA-B27 signal, and they have had a hard time finding things like to remove that signal because it is such a strong signal to remove it. There are other genes that are related to endoplasmic reticulum peptides. So really thinking about these peptidases that cleave up the peptides that would then load the B27 molecule. And so there's been this thing called an unfolded protein response, that maybe B27 doesn't fold well, that it doesn't get loaded well. The unfolded protein response ends up triggering IL-23 production, and then that gets you down that Th17. Now, great question about the heritability, because we know from the epidemiologic studies, again, all in B27, we know that in those studies that if you are HLA-B27 positive and you have a first degree relative with ankylosing spondylitis, your risk goes up 15-fold for the development of disease. But we also know a large number of people, despite those risks, don't end up with the disease. And I want to say it's like 85% of people with risk still don't get disease.
Christy, that was really nice. Over here.
Oh, hi.
Hey. So this is related. Are there any known genetic mutations in the tryptophan catabolism pathway that would increase risk in these patients related to your mouse studies?
Yeah, that's interesting. I don't think that's known, and we haven't looked. We're very interested in trying to understand kind of the bacteria that are really related to that catabolism. And is there a way that we can kind of block those tryptophanases? Actually, thanks to Sean, who loaned us some mutants, some E. coli mutants that weren't able to catabolize tryptophan, we were able to show that mice were resistant to developing disease without that function.
Yeah, Kristine, great talk. Talking about intestinal barrier as one of the pathophysiology of this disease, and working on metabolic syndrome, obesity, that we know that there is problem in intestinal barrier function. What is the association there and between metabolic syndrome, insulin resistance, and?
Yeah, so, we know that in at least psoriatic arthritis, metabolic syndrome is increased in that population. We don't see that epidemiologically within the axial spondyloarthritis population. We really don't see that very much. One of the things that I kind of alluded to with biomarker work that we're very interested in is we have done some plasma metabolomics as well as plasma proteomics, and we're seeing a huge metabolic signature in the way that glycolysis and beta oxidation are being handled in individuals with axial spondyloarthritis. So that's where I'm saying hopefully in a couple of years, we'll be able to share that and have a better understanding. Right now, we see it, we don't know what to make of it.
That was a great talk. I was just curious, your data would suggest that potentially manipulation of the gut microbiota might have an impact in terms of inflammatory signals.
Yeah.
So I was just kind of curious if there's any data to suggest that fecal transplantation or probiotics or something may be beneficial in this patient population?
For sure. So there was on clinicaltrials.gov, there was listed a trial, at least in psoriatic arthritis, of doing fecal transplants. And the last I heard that trial was ended for no efficacy. It gets us into this question that we ask a lot in rheumatology, particularly the group that does more of the RA work, is like, what's that window of opportunity? Because we know that this is leading to the development of that immunity, but once you've already got that Th17 immunity, has that window closed? So do we need to identify the people at risk and modify there?
Some online questions, but while I walk the mic over there, I'll ask, is there a relationship between antecedent to back pain or back injury and these non-traumatic or inflammatory back pain syndromes?
Yeah, not well established. There were some studies done in Europe where they looked at military recruits before and after basic training. And so this kind of gets into that mechanical loading hypothesis. And so what they noticed was that just carrying those 100-pound packs and running daily definitely increases your risk or increases sacroiliitis on MRI. Yes, of course. And then there was some data to follow up, but it hasn't been replicated in other cohorts. One study suggested that maybe there was an increase in axial spondyloarthritis in those military recruits, but that has not been replicated in other studies. I was on a call earlier this week where I'm part of a group that's doing this larger study in North America and in Europe, where they're looking at classification of axial spondyloarthritis. It seems that maybe the Europeans are more readily making the diagnosis than we are in the US. And so, but I mean, that gets into we don't have a gold standard. How do you make this diagnosis? Everything is subjective at the end of the day.
So we do have one or a couple online questions that I'm going to kind of combine into one. Sure. So from Dr. Flores, she says, Stan has demonstrated that eating red meat results in increased production of trimethylamine and oxide by gut microbiota, which contributes to atherogenesis. Would you comment on whether a diet based on red meat also contributes to spondyloarthritis? Part two of that is, we talked about this being kind of a white man disease before. Is there any work being done of genetics versus environment of, should we be worried about turkey season coming up for tryptophans?
Yes. So I'm glad Sonia brought up TMAO, trimethylamine oxide. We dabbled in it. Brendan, who's in my lab, who's worked on this, is probably suffering some post-traumatic stress on this. There's not really that signal in individuals with axial spondyloarthritis. So, diet, red meat, how does that come into play? Those data just don't exist. I don't think that, they do exist. We don't have any correlations or associations between diet and whatnot. Now, I don't know if anybody in the room has done dietary research or diaries and associated with disease and know that those have a lot of caveats in and of themselves. So as far as turkey season, eat your turkey. I don't think we have the data to say that that's going to cause, any inflammatory problems, everything in moderation, right? We really don't fully understand why do some people skew, because actually, let me say this. One thing I didn't talk about is that metabolism of tryptophan doesn't just go to indoles. It goes to serotonin. We need serotonin. And it goes to something called kynurenine. Kynurenine is incredibly anti-inflammatory. So it comes down to the balance. And how is your microbiota or you as a host skewing that metabolism to these different byproducts of tryptophan?
Kristi, great talk. I'm going to ask a clinical question and the first barrier about diagnosis.
Yeah.
So my question is around imaging modality and which ones are the most relevant. It seems to me that there's a lag between symptom onset and radiographic findings. So I guess the first question is, what is that lag? And second is, should we be doing more MRIs, especially when you think about those odds ratios you showed in those high risk individuals? And if so, what would that look like from a sort of a implementation perspective? Getting an MRI here is not exactly easy. And those symptoms tend to be, think of people under 40, 3 months of duration. I may qualify for some of those. So I'm curious about your thoughts about diagnostic sort of interpretation.
Yeah, for sure. So actually, when we do the lag between symptoms and MRI, usually once there's symptoms, especially those classic inflammatory back pain symptoms, and the ones with higher odds ratios, like the early morning wakening, improvement with activity, those have a pretty good correlation with seeing inflammation on MRI. I agree with you, the modalities. Now, there are people whose entire careers are based off of what is the right imaging to do for this diagnosis and what's the gold standard. And my understanding from them is you want semi-coronal stir images as well as T1 weighted. I can tell you on one hand how many times I get the images I want, because radiology is going to protocol it differently. We work with radiology, and I think the study that we're currently doing right now is not only trying to assess the diagnosis in the US and in Europe, but it's also to understand these barriers as rheumatologists and radiologists and get together a consensus of what is the best imaging modality and how do we correlate between those symptoms, X-rays, and MRI. So that's kind of a work in progress. I'm sorry, I rambled on and then I forgot the rest of your question. So, okay.
We have time for one other question. I have a texted in question. It says this is from a primary care doctor. It says the heart of this is, who do you want to see in rheumatology? And the question is, there's so much back pain. It's so common. People often poorly describe it. Can you talk a little bit more about how you would go through this diagnostic pathway, who you would, in relation to Dr. Tropa's question, work up in a more aggressive fashion?
No, this is great. And I think this is kind of what you also alluded to, Vineet. So when I have a patient in front of me who's saying, okay, I've had back pain, it's getting worse, it's been going on for quite a long time. I'm first of all looking at the age of the patient and saying, okay, did this onset before the age of 40, 45? I'm kind of loose on that age range. And then I'm asking them questions. My first question isn't, does activity make it better? Because almost everybody will tell you activity makes my back pain worse. I say, which is worse, morning or evening? If they tell me morning, okay, I'm starting to feel a little spidey tingle. Then I say, okay, how long does it take for you to get as good as you're going to get for the day? I'm taking exercise activity out of the question. I just want to know, how long does it take for you to get as good as you're going to get for the day? And if they're telling me it's taking 60 minutes, a couple hours, I'm highly suspicious, and I'm starting to say, okay, we're going to get a pelvic X-ray. I personally we have it in Epic, a 3-view SI joint. I love that one, because if you don't have them quite straight on, you can kind of get a little angle this way, a little angle that way, and see the SI joints a little bit better. If that X-ray, and I tell the patient, I go, if the X-ray is negative, don't fret, because we're going to do the MRI. Now, if the X-ray is positive, we know to stop. But most of the time, we're going to the MRI. So I have a low threshold. Me getting an MRI ordered, I understand, is a very different scenario than a primary care doc being able to get an MRI approved. But I find that putting in the diagnosis codes of inflammatory back pain, X-ray negative, seems to get it approved, especially when you're looking at the pelvis or the SI joints. So that's been my approach. Now, if the patient tells me they have a family history, or if they have concomitant uveitis, IBD, psoriasis, yeah, you definitely know you have to work that up. So, but I admit it's hard.
This is great, and I think we were right at time. So, Dr. Kuhn, thank you very much.
Thank you all.